this is the case I wanted to share with the group. This was an outside examination that was referred to us for a second interpretation. I'll go through the sequences. There's a T2, the first phase of contrast, 2.5 minutes and 5 minutes. And as I go through this exam, we noticed a lesion in the liver, and I wanted to ask what you guys in the group thought about it.
Any underlying liver disease?
So that's the perfect question. So the patient has hepatitis B.
Leyrat's 5.
Yes, that was
I'm sorry.
If the patient didn't have liver disease, the liver itself doesn't look grossly cirrhotic, but Dr. Chernyak correctly identified that this patient has hepatitis B, and based on that information, this would be a Leyrat's 5 lesion, and that is absolutely correct. So that was my case to share with the group.
So Victoria, I have a question. If very often we don't get any history at all. So in that case, how do you read these things out?
So if there's clear, if clearly there's, there's a, what do you call it?
Cirrhosis.
Cirrhosis, then I just read.
But in a case like this, where really the liver looks normal.
So in a case like this, I usually report and say, these are the features, and then say if patient has confirmed, risk factors for HCC, such as chronic hepatitis B and or cirrhosis, this meets criteria for Leyrat's 5. In absence of such risk factors, the differential diagnosis, blah, blah, blah. So like that. Does that make sense?
Yeah, I was just thinking of what other differential would you give in case we didn't have the history of.
Oh,
I think we were considering adenoma in the differential if the patient didn't have the Hep B. And
neuroendocrine tumor mets will look like this. I have cases like this with solitary mets from like carcinoma and stuff.
Okay. So I was just wondering whether we would have put, like FNH adenoma type of a deal, and then that would be completely
not
off.
FNH, not FNH. Yeah. There was like clear washout. You don't want to put FNH.
Yeah, no, but adenomas can do anything. So
adenoma for sure, but not if the patient has chronic pancreatitis disease. There's no differential.
Right.
All right, so this is a very interesting case that was brought up by our hepatologist, just past liver tumor board. This is a patient who had MR, a few months ago. This is pre-transplant MRI, and MRI was read as, there are these foci of T1 arterial phase hyperenhancement. If you look carefully, you can actually see that there's a little bit of restricted diffusion corresponding to the same level. So if we were to apply Leyrat's, there would, based on major features, there's no washout, it's 8 millimeters. We would go with, Leyrat's 3 based on major features. We can kick it up to Leyrat's 4. It's a tiny lesion. Anyway, so the concern was that the path on the explant came back as 1.2 centimeter combined cholangio HCC. So the concern was that somehow we are, we're missing, there's a big discrepancy between the path and the radiology. So this was a very kind of cool case to illustrate several points regarding the combined tumors. So combined tumors can be, when they're small, they actually are known to meet the criteria for either Leyrat's 5 or Leyrat's 4. So this one would be Leyrat's 4. And, if you look at some of the literature, it's when this happens, it's taken as if Leyrat, as a failure of Leyrat's, meaning that it's an error of Leyrat's 5 diagnosis, right? Because combined HCC cholangio is not your typical HCC. So what we generally want to see, and I apologize, I don't have the access to the old packs, but This is another path-proven cholangio. So this is more of what we kind of are used to seeing, something that looks like LRM. In this case, we have this, ugly peripheral rim arterial phase hyperenhancement. Here's a case that was shared by Milana, also combined a cholangio, and this one has, again, peripheral rim hyperenhancement, delayed central enhancement. Again, this would be a clear-cut LRM, which is deemed to be more correct, so to speak, diagnosis or categorization for these patients. There was a paper that was published in 2019 from Korea that looked at this issue, and the interesting part is that when they looked at survival analysis of conventional HCC groups with conventional HCC versus group with conventional intrahepatic cholangio, and then the patients who had path-proven combined tumor, their curve was kind of like in between. But then when they separated the path combined tumors into those that met criteria for either LR4 or 5, which is the first person I show you, versus those that met criteria for LRM, the curve separated very nicely. And now the tumors that looked more like HCC on imaging behaved like HCC in terms of outcomes, and the tumors that had LRM appearance on imaging behaved like conventional HCC for outcomes. So this was an interesting paper that showed that the imaging appearance may be a better predictor of outcomes in this group of patients as opposed to the actual pathology. So it's a super interesting case because this is not common to catch combined tumors when they look this innocuous, when they're this small, but it's not a rat path discordance, and this patient should do as well as a person with conventional HCC given the imaging appearance of this thing. Any comments?
Victoria, did you say they biopsied it or resected
this was
it?
This was an explant. That's why they were so concerned that this was, based on the report, they just described this foci of hyperenhancement, nothing specific, and then on path on the explant they found this fairly aggressive tumor, so that they were concerned why there's such discrepancy between what the report showed and what the final path showed. But again, this is not a discrepancy, basically.
Yeah, and it seems like, say it had come back on biopsy, it's still, if like in the long run we think that the graph that you showed is true, they would not be excluded from transplant, or like if it had been a biopsy ahead of time and showed imaging.
I believe that technically, if there's path-proven combined tumors, okay, don't quote me on this, but I think that may be not contraindication to try, or they may have to make a case for opt-in to proceed with transplant. So he got lucky that they didn't biopsy before the transplant.
Victoria, is there any data on the long-term outcomes of combined tumors who get transplanted, like in terms of extrahepatic recurrence following transplant, or what their longevity is like?
Not that I'm aware of. Again, we rarely see these tumors at this stage, very early, like with this appearance very early. Usually they're more into LRM situation. So I not off the top of my head, I would have to look it up, but not aware of something major that. And again, I think that if you have path proof this is a combined tumor, patients don't generally go for transplant.
Mm-hmm.
All right, so the next case, let me just make sure that I'm not flashing the patient's names. Is it more of a acute kind of case? So this is an incidental finding here. Any thoughts?
Is the epicenter urethra or pubic symphysis as you go?
Perfect
Do you
question.
have the sagittal?
Yeah.
Perfect question, because my first thought was that we're dealing with some sort of clitoral thing. But on coronal, right, and I'll show you the sagittal in 1 second. You can see that the epicenter is not bad. That's the epicenter.
Looks extra
Yeah.
GYN.
I'm sorry?
It looks
Anterior
like
to
the epicenter is coming from the pubic symphysis rather than the urethra. Like
Can you show
initially
the
I
bone
thought,
windows? Sorry, go ahead.
I'm trying, sorry, I'm still learning the specs. Anna, don't laugh at me.
not at all. Can I help you change the?
Yes, I don't know. I don't know what I'm doing. The problem also is I have a regular because I'm logging in from remotely, so I don't have the funky mouse that we use.
Right.
Let's see.
It's like a rind of like tissue around the
Right. So this is right under the pubis. This is a urethra, right? So this is not a good location for periurethral, urethral diverticuli. This is not a great location for for gardeners, obviously, for for
Bartholin.
not Bartholin, the other one, that's for skenes, right? Skenes is going to be more here. So this is kind of the region of the clitoris, so this is not great. So this is really associated with the pubis. Again, I think the coronal kind of shows it the best, that it's really there. So this one has a, I found a case report on this entity. And this is a subpubic cartilaginous cyst. And here it is on MR, right? It looks identical to what we see on CT. And these are just kind of degenerative things that happen when you have kids. So, and they're cysts and they have these cartilaginous material in their capsule. So it just was an interesting finding, probably of no clinical significance to this patient whatsoever, but cute finding.
Victoria, that's super cute. I was thinking, like Nellie said, so you weren't concerned, there was no concern for osteo, and then this is almost like some kind of synovial cyst coming out of the joint kind of thing, but it happens to be lined with cartilage.
Yeah, that's what initially, when I start looking for stuff, I thought that maybe I start looking for synovial cyst, around the pubis, and then I somehow found this one. I was like, oh, this is exactly what it looks like.
Is it dental or was the patient symptomatic?
No, this is incidental. Patient has cancer, so it was just a cancer follow-up. So
nice.
Yep. Those are my two cases. I'm still collecting.
I have two cute cases. I can go. So this is an older gentleman who came in for abdominal pain, had a CT, and the interesting finding is in the pelvis right here. So I'm going to run slowly through the axials of the contrast enhanced CT pelvis, and then move on to the coronal, and I'll show you the sagittal images as well. So this is what it looks like in coronal. That's the bladder here.
There's some hypertension.
Yeah, indeed. And then I'm going to pull up the sagittal and show you.
Hematuria?
No hematuria. He just had some vague abdominal pain. So here is the sag. That's the bladder. I'm just following on the theme of pelvic lesions from Victoria's case. Pubic symphysis, prostate, and then, like you rightly pointed out, Nelly.
Vesicles or something is pushing.
Yeah. So, and then there was a tail-like thing connected.
Diverticulum?
It didn't fill with urine. This was a single phase. There was no delayed, no contrast filling in this area. But anyhow, he subsequently, we weren't sure what this thing is, and he got an MRI to follow this CT. So let me show you the MR. I'm wondering if, okay, here we go. So this is the coronal T2. That's the bladder, prostate. And here is the thing that we saw on CT. It's very dark on T2.
All right, cool. All right, thanks.
That's
A pretty fibrous tumor of some sort.
good thought. I'm going to show you more images. There's another finding that goes with this finding, which I showed you on the coronal, and we'll come back to it. Let me show you the axial T1. So this is the pre-contrast T1 axial prostate. Intrinsically bright on pre-contrast T1. And then there is this
vesicle.
tail-like thing. Somebody's on the right track there, bladder. This thing doesn't enhance on the post-contrast. I'm going to go back to the coronal.
Is it like an obstructed ejaculatory duct? Do you get this uber?
You're absolutely on the right track. So if you see an obstructed ejaculatory duct associated with a dilated cystic structure, any thoughts in that direction? And then there's another clue to this syndrome.
There's that the pancreas cystic fibrosis. No.
Anything
the
else?
kidney is absent.
Left kidney is absent, exactly. So this is Zinner syndrome. I don't know if you guys have heard of this. This is basically a triad of unilateral renal agenesis, ipsilateral seminal vesicle cyst, and ejaculatory duct obstruction. These patients can present with symptoms related to this obstruction, with perineal pain, painful ejaculation, infertility, etc. But this was, I mean, his abdominal pain could have been, it wasn't necessarily perineal pain. Maybe it was related to the obstructed ejaculatory duct and seminal vesicle cyst, but something unusual. And then on the same MR, there is another thing that I wanted to point out. So when you look at the diffusion, so let's look at the T2 first. On T2, this structure is very dark. And on the diffusion, this is the B800. It's very dark on B800, also dark on the ADC. So this is a phenomenon which is like opposite to the T2 shine through. And I thought this was a nice example of T2 blackout effect, where the ADC is dark, but the DWI is also dark, not bright. So this is not true restricted diffusion. And it is a phenomenon that is opposite to T2 shine through, called T2 blackout effect. So just a cute.
What causes the T2 blackout effect?
I think this person has either hemorrhagic stuff, blood products, not either. I think these are blood products within it, because it's super bright on T1 as well and very dark on T2. So blood degradation products can cause that T2 blackout effect.
When you start out with really, really low signal on T2, that's what that's what it is. And usually it's chronic blood.
Yeah.
But that's what it means, because you already start out with very low signal on T2. So when the ADC map is created, it retains the dark signal.
Yeah, it's more commonly described in the brain with blood degradation products. Less, I mean, Victoria, you must tell me, but I haven't seen this phenomena very commonly in the abdomen.
It's for the pelvis is described in endometriomas. It's a common phenomenon in fibroids, because they start out with such low signal intensity on T2. So that's one of the pitfalls for ADC in pelvis.
Regino got it in the chat, and he's also logged in twice, which is funny because I'm logged in twice, but the other person who's logged in as me is Roopa. So if everyone thinks I'm like chatting extra, it's because Roopa and I are both chatting under the same name, and Regino is logged in twice. He said to give more of a presence. So
awesome.
But anyway, Regino got it. Zinner syndrome.
Nice. Excellent. Yeah. All right. So I just wanted to run through this. This is literally a show and tell. This nice Doppler cine. I don't know if you can actually see the grayscale on this.
Ureterocele?
Yeah, indeed. This was a cute fire-spewing ureterocele. This was an incidental finding in an older person. nothing to do with the Weigert-Meyer and pediatric ureterocele. All right, I'm going to stop sharing. That's all I have. Okay. Someone else can go ahead.
Aarti, I have a quick show and tell case also.
Did you coin the fire-spewing ureterocele? Is that?
Say that again.
Did you coin that? Is that?
Yes.
Can I quote you?
Yeah, they call it the cobra head sign, but the fire spewing is my invention.
I like that better than the cobra head.
Thanks.
Christine, do you want to go next?
Sure.
Okay.
Okay, so I have here a 31-year-old who had an MRI actually for epigastric pain. And I wanted to show this case because she has multiple liver lesions. So this is an outside study. I believe they use Gadavist. And on the early arterial phase, you can already see that there are multiple masses in both lobes. And if we go to a portovenous phase, this looks to me that maybe some of these are washing out, and maybe some of them have like almost like a pseudocapsule appearance to me as well. And then what's peculiar to me is that on the T2, these are kind of dark on T2. So,
do they have intracytoplasmic fat?
That's a great question. I don't think so.
Any risk factors for adenomas?
Not that we know of.
But it looked like the background liver is fatty. So, like, for example, that washout, like slight washout might have been because the background liver was fatty, but it still could be FNH.
FNH, yeah. Still thinking.
Okay.
Yes.
Yeah, I did recommend just repeating the scan with Eovist and seeing what they do. It just, oh, I see what you're saying. So maybe the lesions look slightly T2 dark because the background liver is fatty, right?
Yeah, exactly.
Yeah.
And then maybe that slight washout, like I think FNHs can have like that slight washout appearance, but it gets exaggerated if the background liver is abnormal or fatty.
That makes sense. That makes sense. Okay.
I feel like one of the lesions has a scar too on like post-con.
Yeah, like this one here, right?
Yeah,
It
sort of like a
as a
lesion,
scar.
hallucinated scar. Yeah.
I would have to very respectfully state, you know, I would be very, very cautious with thinking about FNH whenever you have any washout. And it certainly needs a workup. And with this appearance, I mean, I still would think more of adenomas.
Wait, go back to, Christine, go down to that lesion you just showed with the like slight washout. I've seen that a lot. And one thing that I think is that because it's displacing vessels also, it gives more of that appearance of like, it doesn't have.
So think about it. If you have a fatty liver, first of all, I don't think this patient has such severely fatty liver. But if you have a really fatty liver, right, it will suppress the signal intensity of the background. You actually are less likely to have washout. Think about it, right? If you have the curve of the liver enhancement, and now you have so much fat that it kind of knocks out the signal from the background, it's actually more difficult. It actually can obscure the washout rather than exaggerated. So I don't know, I've seen atypical FNHs, but with this appearance, I'd be very concerned. I would not just let it go as an FNH until you have a very convincing EVIS study and or biopsy. But with this appearance, I would kind of be leaning toward the adenoma.
Okay, thank you. Yeah, that's super helpful.
Can you follow up the EOVIST? Yeah.
Yeah, for sure. So I recommended EOVIS with, and then after that, possibly tissue sampling. So I'll come back and let everybody know what we get.
We can have our first wager, Victoria.
I know. I was just about to chat in. I'm gonna put my bet on FNH, and then we'll get the.
And push-ups.
Steve,
Oh
wait, Steve. What is Steve? What is Steve?
Steve is wagering 1,000.
Wait,
He's at FNH.
Steve is wagering on FNH.
No, I'm not wagering anything. I'm laughing because you guys are actually wagering, and so I throw in there $1,000 just for fun, and then you guys are like, "Oh, look, Steve's offering up $1,000 for the right diagnosis." No,
It's all virtual money, so it's okay.
I like. Somebody said push-ups. Let's do push-ups. RT.
I can do like 2 push-ups.
Great. All right. How about this? No matter the outcome, we all do push-ups.
Okay.
When we get a follow-up, the entire group, whoever wins, we all do push-ups because
With video
On camera.
This
On
way,
camera,
we all are winners.
Okay.
I don't like calling FNH when it's not disappearing on all the
Yeah.
non-contrasted sequences, and
Yep.
it's because the iron content and the fatty liver, it just messes with you, and you don't know what you're looking at anymore.
I'm with Steve on this one. See, Steve is gonna do push-ups with me.
Okay, and I am gonna bring you a companion case where there's like this mild washout, and it was a biopsy-proven FNH. So
It can happen. It rarely does happen, but this is not something that you should call just based on imaging. This requires complete workup, including biopsy.
okay, who else?
I just have a quick one, Arti. I can go.
Yeah.
So it's a straightforward one, but okay. So patient with known history of pancreatitis. He had gallstone pancreatitis, so he ended up getting a cholecystostomy tube. He was renal failure and everything, so couldn't get surgery emergently. So he has a chole tube. And then he has this, and then presents with hematemesis. So this is we did a GI bleed protocol. So
Our
this,
GI folks are placing those things all the time.
yeah, they are endoscopically. So any observations on the non-con before I go to the post?
Wait, I'm confused. That reservoir looking thing, what is that connected to?
It's in a collection. There's a small collection.
Oh, it's a cystgastrostomy. Okay, got it.
Cystgastrostomy, yes.
Maybe the material in the stomach is kind of dense, like there's
Right,
peat in there.
right. So hyperdense material with expanding the stomach. That was consistent with history. And then when you look at post-contrast, I'm just scrolling through the relevant images, that's all.
It's like
Oh,
a
there's like a
splenic
pseudo
artery.
aneurysm or something like that next to this gastrostomy.
Yeah.
Right, so that's a pseudoaneurysm which had formed off of the splenic artery, and then that was what was bleeding into this. Unfortunately, this patient actually died.
Yeah.
Yeah, so these things can happen.
From
And then-
exsanguination? Like what do they do?
Yeah, of exsanguination.
Oh, wow.
Of exsanguination. And this is sort of a companion case, except look where the cystgastrostomy stent went in here. There's 2 of them. One is in the collection with the other end in the stomach, but then.
You can have a case series on like malpositioned axios.
Yeah. So this one went into the spleen, obviously. This one, they did an emergent removal. So these things can go to different places. So I just want to share a few slides on these things.
And Roopa, my endoscopist often will ask me like if there's gastric varices between like a walled-off necrosis in the stomach. They don't want to put those, but I didn't really think also, the splenic artery is also right there.
Yep. So these are different ways. They call these LAMs, lumen opposing metal stents. They used to do these via plastic stents, but the nice thing with these metal ones is that they are self-expansile. So if it's a more complex collection, and even if it's truly a walled-off necrosis, these things get them better than the plastic stents. They are wider bore And they have these self-expanding flanges which hold on better to both sides of the gastric wall as well as the collection. And they can remove.
So is LAMS the generic term of
Yeah,
which
LAMS is the generic.
Axios is like one type?
Axios is the brand. Yeah,
I see.
I think that's the most common brand most places use.
Yeah.
But there's a nice radiographics article which goes through this, and they call it LAMS as the generic term. Yeah, like our case, we can have bleeding. It can be due to direct puncture, like Aarti said. That's why the endoscopists want to know if there are vessels in the path, or the pancreatitis itself can induce pseudoaneurysms. And this was interesting with metal stents. They said the incidence is actually higher because these things don't retract like the plastic ones do. So the vessels actually undergo stretching, and that's how these pseudoaneurysms happen. As the collection decompresses, the pseudoaneurysms form because of that stretching effect, which is why they say if you put in a metallic stent, you have to do a CTA follow-up in 3 weeks if there's any concern. These can migrate, like we saw the splenic one, they can go into the GI tract. There are case reports where they've called bowel obstructions because of migrated stents, and they have to endoscopically retrieve them. They can have ingrowth and get buried in the stomach wall. And this is a helpful reporting template. This is that radiographics article. So these are things to pay attention to. Is what is the proximity they like within a centimeter is what the distance where they like between the wall of the cyst and wall of stomach or duodenum, depending on where they're going. And then any varices, any vessels, and then post, these are the things we're supposed to report. So it's just an interesting set of 2 cases related to each other.
So this was a 79-year-old female who was diagnosed with recent diagnosis of pancreatic cancer. And this was for initial evaluation. So changes of chronic pancreatitis. I think this was, they did an FNA and got malignant cells, but I really couldn't see any measurable mass in the pancreas, but it's just for like evaluation. And then there is a liver lesion here. So I just wanted to ask everybody, how would they read this out? So that's the arterial phase, that's the portovenous phase, that's T2. And coronal T2.
Sort of an unusual thing for a Met.
Yeah, it didn't look like a classic Met when the primary is not even seen well. And
yeah, unless neuroendocrine sometimes does that.
So when we reviewed the history a little bit more, this patient had Hep C positive, was Hep C positive, but obviously the liver doesn't look very cirrhotic. So because of arterial enhancement and washout, we questioned HCC and rather than a metastatic lesion, and that's what it turned out to be. It turned out to be a well-differentiated HCC on biopsy. But when I put this case for follow-up, and I kind of forgot about it, but it was later discussed in a meeting. And then another twist to it was this patient also has history of multiple myeloma. You can look at the bones. And then one of the differentials that came was whether, now it's a biopsy-proven HCC, but before the biopsy, the discussion was whether this could be extramedullary disease. And over here at UMS, we look at a lot of cases of myeloma, and we get to see a lot of extramedullary disease, and extramedullary disease in the liver can look similar. They're arterially enhancing lesions. The only difference is they don't show a whole lot of washout. They tend to stay enhanced. Sometimes occasionally lesions can have central necrosis, but they don't show a nice washout and a pseudocapsule like this lesion is showing. So complex history, pancreatic cancer, then had Hep C positive, and then he also had multiple myeloma. She also had multiple myeloma. But I think the teaching point here was, this is the dictum that I follow. I don't know what Victoria has to say, but anytime I see arterial enhancement, washout, and pseudocapsule, with any presentation, I at least question HCC and recommend a tissue sampling, and just rather than saying that, just given that they have a primary malignancy, this is possibly a MET.
Right. So unless the patient has, parenchymal liver disease, in which case you don't need to do the biopsy.
Yeah.
Even if there's primary malignancy somewhere else.
Victoria, you must know the literature well, and I'm not trying to put you on the spot, but I've always kind of pondered why hepatitis C is not sufficient to LIRADS things. It's just not statistically enough, huh?
So hepatitis B, the virus itself is tumorigenic. So it can induce tumorigenesis in absence of cirrhosis. But hepatitis C virus, for whatever, I'm sure the virologists know better why, but for whatever reason, hepatitis C is not tumorigenic in and of itself, and the cause of HCC is a cirrhosis, not the virus itself.
Right. Okay.
So the for LIRADS to work as it intended, it needs it needs high enough pretest probability of HCC to to meet the post-test positive predictor value that we need.
Right.
So there's some literature that shows that advanced fibrosis with hepatitis C may be enough, and so we may expand the criteria in the future releases, but for now, it's not.
But by the time they have advanced fibrosis, it's probably imaging evident anyway.
It often is.
Not always? No.
Not always. I mean, I have cases with biopsy-proven cirrhosis and liver looks pristine. And the only inkling you may get is that the EVIST is that has that little texture to it instead of being very smooth.
Okay.
Okay, can you see my screen?
Yes.
Okay, perfect. So maybe the cases are not as interesting as your cases, but just a couple of cases with some interesting findings. So this patient, 52-year-old, was referred to us with rectal mass for staging, basically, and they've shown the key images that we highlighted. So this was the primary mass, basically, and it was extending through the mid and lower rectum. We thought that there was some extension here, making it rendering it a T3 disease with even EMVI and nodal disease. So anything unusual, or probably show and tell. But basically, this case, the patient underwent, so he was referred with rectal mass based on exam, but was taken to OR for examination under anesthesia, and also to have biopsies of the tumor. And when they went in, they noticed only a posterior ulcer without any focal masses. And this was biopsied, and they sent serologies and worked up the patient, and turned out he's positive for chlamydia. And so this was
positive for what?
Chlamydia.
Oh wow.
Yeah, and it was actually lymphogranuloma venereum, which is one of the great mimickers for rectal masses, specifically rectal lymphoma or rectal cancer. But this was basically the case in this patient. And from the literature, we don't have large number of cases, but they say in these cases you will see more submucosal edema than you would see with cancer, and you might see engorgement or enlargement of the seminal vesicles, which maybe you can say here, but it's not really specific. So we actually called it a tumor, and we staged it based on the primary suspicion. However, given the final findings, we thought that this warrants at least some follow-up.
Do you have the GWI?
Yes, we do here. Sorry, it's not very zoomed in, but we see the lymph nodes standing out.
So it doesn't really restrict? Oh.
Yeah, it didn't really restrict. There were some signal, just edema mainly, and but the thickening did look real, on the T2. It did look real, like what we'd see with masses, and it did look mass-like.
Yeah,
it wasn't very diffuse. You see the rest of the rectum and even the sigmoid were completely fine, and the stranding wasn't circumferential. It was very at focal areas. And I'll show you the other T2s, but the edema was certainly maybe more than usual.
Yarab, did you say he was HIV also?
He wasn't HIV, so that was the confusing thing, even for them clinically. But he was.
I'm sorry.
For, STI and chlamydia.
like for chlamydia, sorry, and I think syphilis as well.
Okay.
Yeah.
Jared, that was really cool. Thank you.
Thank you. I have another case if there's time for it. But again, sorry about that. Okay, so this is more like, so in the line of liver masses and liver tumors. So in this patient, actually a 78-year-old male patient who on, I think cardiac echo had like decreased venous return, and basically they were just scanning and screening also for abdominal pain. So they did this CT scan of the abdomen, and you notice here, like on the axial, looks like a filling defect into the hepatic veins and IVC, which could have been a mixing artifact. But if you look here on the coronal, looks very real and mass-like. And you can see on the, we did a contrast enhanced MR, but unfortunately it was a non-breathold. And this was the most delayed phase. Maybe there are specks of enhancement, but not very avidly enhancing. And unfortunately, we don't have good subtraction, but definitely it was restricting. And it was restricting as much as like the spleen. Any thoughts? So this was, sorry?
Fibrolamellar?
Yeah, so actually it was like, there was part of it into the liver, but there wasn't like any arterial enhancement or washout. It was showing this high grade of restriction, and it was, the epicenter was mostly within the IVC and part within the liver, as you can see here. So this was biopsied and actually turned out to be a lymphoma with primary involvement basically of the IVC. And this is not actually very common. And even looking at the literature of intravascular like lymphomas and tumor thrombi that turn out to be lymphoma, it's very rare to get the IVC. Like there was a case series of 14 cases, like 2 of them were in the IVC. And similar to this patient, 1 of them had like a diffuse large B-cell lymphoma. But it's just good to put it in mind and not to dismiss this filling defect quickly on the axial without looking at it further.
Wow, did the patient have lymphoma elsewhere? Or that was the only
No,
spot?
so that was the interesting thing. No lymphadenopathy, no disease elsewhere.
Definitely diagnosis of exclusion.
Yeah, definitely.
Yeah, common.
Awesome.
Thanks, Yaram.